We have finally made it to the end of HIV week. I never really thought this day would come, but finally, I've taught you everything that I know. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we look at medical topics in depth. Today we'll look at HIV opportunistic infections, IRIS, as well as some malignancies that are associated with HIV. If you haven't yet subscribed to the channel, please hit the subscribe button, hit the bell notification icon to be receiving notifications every time I post. Drop a like, drop a comment, grab your piece of paper, and let's go. In the past 6 videos, we looked at the HIV basics, we looked at the diagnosis in adults, we looked at an interlude where we looked at the HIV drugs, we looked at the treatment guidelines in adults, we looked at the treatment guidelines in pediatric children, we looked at the treatment guidelines in pregnant women. In this lecture today, we're going to be looking at opportunistic infections, malignancies, as well as IRIS that is associated with HIV. We will have a live stream on Sunday at 19 hours. Please make sure you tune into that. All the courses will be covered where we will now be applying the different information that we have learned from these lectures over the course of the week. So in view of our style of doing our lecturing, a 27-year-old HIV positive man comes for a revisit after a screening urinalysis reveals strikingly elevated protein levels. The patient is currently reluctant to start antiretroviral therapy, though he is taking prophylactic antibiotics. He has a distant history of injection drug use. On examination, the patient has mild ankle edema and is slightly cachexic, but otherwise appears well. A new urinalysis reveals 3+ proteinuria. It also is not without hematuria or any red cell casts. Serum albumin is 2.3 grams. Which disease process is most likely to explain the patient's proteinuria? Minimal change disease, focal segmental glomerulosclerosis, membranoproliferative glomerulonephritis, membranous nephropathy, as well as IgA nephropathy. You may pause the video right now, scream the answer at your screen. I will give you the answer at the end of the lecture. So we'll start by looking at what IRIS is, and not the IRIS that you know, another type of IRIS. So this IRIS just simply stands for immune reconstitution inflammatory syndrome. This is just simply going to be defined as an exaggerated inflammatory reaction from a reinvigorated immune system, presenting as one of the following things. Presenting as either number 1, unmasking of previously subclinical opportunistic infections, 2, clinical deterioration of the pre-existing opportunistic infections, number 3, development of an autoimmune disease. So the unmasking, so IRIS has 3 main types: the unmasking type, the paradoxical type, which is the clinical deterioration, and the autoimmune type. Sometimes there can be a mixture of the 3, or a mixed type. So you can think of it like this. Suppose we're in the country and the military, we have the military people in the country that are supposed to protect the citizens, but let's say we don't have those military, or they're being killed off silently by a disease of some sort. It means that even if the enemy were to invade the country, we wouldn't be able to actually fight against the enemy because the soldiers are not there. But once we now recruit soldiers, we're able now to fight. Now when we're fighting against these enemies, then of course, remember when 2 giants are fighting, the grass tends to suffer. So us who are not part of the military are pretty much going to be suffering. That's a similar thing of what is happening in IRIS. Someone had an immune system that was in the toilet, meaning the CD4 count was very low, the viral load was very high, then they may have collected some opportunistic infections that were not really picked up by the immune system, or they may even have an opportunistic infection currently. Then what happens is that you start this patient on treatment. And as you start this patient on treatment, you get to unmask, you get to realize that, oh, there's an opportunistic infection that's there because the immune system is now recovering and starting to fight against these opportunistic infections that were subclinical, that were remaining hidden. Alternatively, if you have an opportunistic infection and you start the patient on antiretroviral treatment, the immune system gets better, it starts fighting against the opportunistic infection, the patient begins to deteriorate. They begin to appear as if they're getting worse, because of pretty much an exaggerated inflammatory reaction that is happening. Now, the onset is usually 2 to 12 weeks after you start the ART, and the frequency is about 10% among patients that are on ART, up to 25% when the ART is started with individuals with a CD4 count less than 50 cells. Like I said, a very low CD4 count. Now, what are the risk factors of developing IRIS? So initiating ART close to a diagnosis of an opportunistic infection. So usually we first start the treatment for the opportunistic infection because the patient can die because of the opportunistic infection. HIV most likely will not kill the patients. Then we initiate the ART when the CD4 count is less than 50 cells. This also is a risk factor of developing ART. But of course, now we do start them on treatment regardless of the CD4 count. And of course, rapid fall in the HIV-1 RNA levels in response to the ART in patients who have a low CD4 counts. And so patients, if it's a very effective treatment and it drops the viral load very, very quickly, and still they have a low CD4 count, and then the CD4 count begins to pick, it may actually exaggerate the response of the immunity. And then this is commonly seen with conditions like TB, Cryptococcal, Kaposi, sarcoma, Mycobacterium avium complex infections. And patients initiated on DTG and with a low CD4 count have a higher risk of actually having IRIS. How do we manage patients that come in with IRIS? So you have to have a high index of suspicion with early complications. So the ART should be continued. Don't stop the ART. So if it's not possible to continue the ART, you can temporarily interrupt it, then restart with the same regimen after you have addressed the opportunistic infection or after you have addressed the IRIS. We should diagnose and treat any opportunistic infection or any inflammatory condition. Corticosteroids are used for moderate to severe cases where you give prednisolone 0.5 to 1 milligram per kg per day for 5 to 10 days. We move now on to the opportunistic infections, malignancies, and AIDS-defining illnesses. I'll just highlight a few of them. I won't talk about all of them in a lot of details because these are topics on their own. So we'll look at CNS toxoplasmosis, cryptococcal meningitis, progressive multifocal leukoencephalopathy, CNS lymphomas, pneumocystic jirovecii pneumonia, chronic diarrhea, Kaposi sarcoma, lymphomas, as well as cervical cancer. So what are the neurological manifestations of HIV? Remember that these are the neurological system is the second most commonly affected system next to the respiratory system. The respiratory system is the first, followed by the neurological system. So they can actually happen at any stage of the patients that have HIV disease, and it can actually affect any of the parts of the neural axis. Then of course the clinical manifestations are variable. They can be either directly as a result of HIV, where a patient can develop aseptic meningitis, AIDS, dementia complex, which are things like acute demyelinating distal polyneuropathies, mononeuritis multiplex, and even some distal sensory polyneuropathies. You may have some myelopathies, peripheral neuropathies, myopathies, and even vasculitis. These are just directly related to HIV. It may also be secondary immunodeficiencies like opportunistic infections, CNS toxoplasmosis, cryptococcal meningitis, tuberculous meningitis or tuberculoma, progressive multifocal leukoencephalopathy. You may also have CMV polyradiculopathy or encephalitis. You may also have some opportunistic malignancies like primary CNS lymphomas. Or indeed, the neurological manifestations may be related to the ART. So you may have peripheral neuropathies in terms of didanosine and stavudine. You may have myopathies in terms of zidovudine. You may have psychiatric manifestations or psychosis in terms of efavirenz. Now, what are the neurological manifestations directly related to HIV? You may have aseptic meningitis. So this can actually occur at any time during the course of HIV, and it's most commonly at the time of acute HIV infection. So as the infection actually proceeds, it's increasingly becoming rare, and it usually just follows development of AIDS. So patients are going to have headaches, photophobia, and sometimes even frank encephalitis, and they may even have these cranial nerve involvements. Most commonly, cranial nerve number 7 is affected. Then, of course, in the CSF findings, you may see some lymphocyte pleocytosis, about 10 to 100 cells in the CSF, increase in protein levels, normal glucose levels. Of course, your diagnosis of HIV should be used to confirm this. We already talked about the diagnosis and how HIV is diagnosed. Then, of course, the syndrome is usually resolves spontaneously within 2 to 4 weeks. Then when it comes to AIDS dementia complex, this is actually an AIDS defining illness in up to about 5 to 10% of patients. It's a major cause of dementia in the young people. So a major feature of the entity is actually the development of dementia, which is going to be defined as a decline in the cognitive ability, the motor, as well as behavioral dysfunction. Now, in the cognition, you can divide the cognitive, behavioral, and motor aspects into early, middle, and late manifestations. So in the cognitive dysfunction, in the early phases, you may have inability to concentrate. In the middle phases, you may have mental slowing and forgetfulness, and then late phase, you have this global dementia. Then the behavior early on may be outed personality. In the middle age, it may be social withdrawal. Then in the late stages, it may be apathy. Then in the motor, in the early, you may not get anything. And then middle, you have poor coordination and paraparesis in the late phases. Diagnosis is, of course, neuropsychological tests, a mini mental state exam. And then, of course, it's often a diagnosis of exclusion after you've excluded all the other possible causes of dementia. Then, of course, treatment is with your antiretroviral treatment, especially those that are able to penetrate the CNS. Drugs like zidovudine, stavudine, abacavir, nevirapine. Then, of course, supportive care. Then with peripheral neuropathy, it occurs in a third of the patients that have AIDS. Most likely it could be affecting a single neurons or single nerves. You call that as a mononeuropathy, like Bell's palsy, which is affecting the 7th cranial nerve. It could be a mononeuritis multiplex or a distal sensory peripheral polyneuropathy. So this is actually the most common presentation, where you get this symmetrical bilateral painful burning sensation. There may be paresthesia, you may get this tingling of the feet and even the lower extremities. Usually the diagnosis is clinical. We may do a nerve conduction study, and it's often a diagnosis of exclusion. And of course the treatment is symptomatic treatment. We discontinue or we change the drug that's causing this peripheral neuropathy if the symptoms are actually quite severe. Then you may have CNS toxoplasmosis, which I'll take some time on. So remember that this is actually caused by a protozoa known as Toxoplasma gondii or gondii, however you want to pronounce it. It's a zoonotic infection. We get it from cats, and cats are actually the definitive hosts. The cats can actually excrete oocysts in their feces, and these oocysts can be transmitted from the animal to the humans. Now, how do we get this? We may sometimes get Toxoplasma gondii from the cysts, which are found in undercooked meat. This is actually the second most common cause of secondary CNS infection in patients with AIDS. It generally is a late complication of HIV, so it's going to be occurring when an individual has a CD4 count that's less than 100. It is thought to actually represent reactivation of a prior infection that you have collected a long time ago. How is it going to be presenting? Onset is going to be subacute. You may have fevers, headaches, hemiparesis, seizures, altered mental state. You may have focal neurological signs in 90% of the patients. You may have an encephalitis picture where there's confusion, which is quite common. You may even have coma. You may even have the patient becoming more toxic. Then, of course, the areas that are going to be affected are going to be the basal ganglia, the brainstem, and the cerebellum. And then you may also have some extracranial manifestations like chorioretinitis, myocarditis, and even pneumonitis affecting the lungs. So our diagnosis is pretty much clinical, a physical examination and a history. You may also do a CT scan or an MRI. You're going to be seeing these multiple ring-enhancing lesions in 90% of the patients with a mass effect and edema. So you get a solitary lesion on the MRI that makes the diagnosis unlikely. If you get a solitary lesion, like for example, one that is shown here on the right, here is a ring enhancing lesion with adjacent edema that is surrounding. But with this ring enhancing lesion, it's usually just one. Most likely this is a pyogenic cerebral abscess. You may also see this with a CNS lymphoma, but usually they may even be much larger than this. With the CNS toxoplasmosis, you get these multiple ring enhancing lesions. Then there may be some preferential location where you see these lesions, basal ganglia, gray white matter junction, and even the white matter. I will show you a picture when we look at the live stream tomorrow, actually on Sunday, not tomorrow, on Sunday, when we actually look at the questions. I will show you a question about CNS toxoplasmosis. Then of course you may have a therapeutic trial plus or minus histology or biopsy. So brain biopsies in patients with treatment failure. It's not possible in Zambia. Then of course serology is of limited value, and a negative toxoplasma antibody test makes the diagnosis actually unlikely. So you may do a toxoplasma antibody test. Then what's the treatment? So there are 3 regimens that I want you to know. The first regimen uses a loading dose of pyrimethamine 200 milligrams. So you give a loading dose of 200 milligrams, then 50 milligrams daily. You combine this with sulfadiazine 2 to 4 grams per day, and folinic acid 10 to 20 milligrams a day. That's the first regimen. The second regimen uses Fansidar, which is pyrimethamine 25 milligrams and sulfadoxine 500 milligrams plus folinic acid 10 to 20 milligrams per day. Now remember that you're going to be taking 2 tablets of the 525. So the Fansidar, 2 tablets of Fansidar twice a day for 2 days, then 1 tablet once a day. Then if the patient is very critical, you can actually add doxycycline 100 milligrams twice a day. Then the third regimen uses pyrimethamine and clindamycin, because there are patients who are reacting to sulfur containing drugs. So pyrimethamine loading dose of 200, then 50 milligrams a day, plus folinic acid 10 to 20 milligrams a day, then clindamycin 450 milligrams 8 hourly. So remember, clindamycin and pyrimethamine are used in patients that are allergic to sulfonamide. Then of course the duration is 6 weeks or 3 weeks after the complete resolution of the CT scan lesions. And then you may also continue suppressive therapy with pyrimethamine 25 milligrams a day, sulfadiazine 2 grams a day, and folinic acid 5 to 10 grams a day. Generally, you should start them on treatment when they are clinically stable, which is approximately about 2 weeks after the acute presentation, to prevent IRIS, which I already talked about earlier on. Then the side effects of the drugs include leukopenia as the main side effect of the treatment. So a high dose of Fansidar, the 2 tablets, has been found to actually be associated with fatal hemorrhage. You may also want to check for any bleeding tendencies, such as bleeding from the gums, nose bleeding, even hematuria. Do an FBC at least once a week. And then to prevent these side effects, we often give folinic acid 10 milligrams orally a day. Then if there is any bleeding tendencies, you stop the Fansidar and you start them on doxycycline 100 milligrams twice a day. Alternative regimens are going to be giving cotrimoxazole or clindamycin plus pyrimethamine or primaquine, azithromycin, clarithromycin, or doxycycline. There is an indication of using steroids sometimes. If there is evidence of marked increased intracranial pressure or altered mentation, we can administer dexamethasone 8 milligrams stat, then 4 milligrams IV, which we can give QID. Then of course, this is until the suppressive or the maintenance therapy. So the Fansidar 1 tablet a day should be continued, and then the suppressive therapy can be stopped when the CD4 count is at least greater than 200 cells for at least 6 months. Then of course the prevention for all patients that actually have a CD4 count less than 100 cells per microliter of blood. This was actually even moved to about 350 in the newer guidelines that I've been teaching on the channel. So we use trimethoprim and sulfamethoxazole 2 tablets per day, trimethoprim, sulfamethoxazole 2 tablets 3 times per week. Alternatively, dapsone plus pyrimethamine plus folinic acid can be used. So primary prophylaxis can be stopped actually when you have the CD4 count greater than 200 cells for more than 3 months. But of course, there are different other ways in which you can start and stop this. I talked about this in the previous video. I'll leave it tagged at the end of this video. Then we move on to cryptococcal meningitis, which is pretty much caused by cryptococcal neoformans. Remember that they are pretty much 2 variants: cryptococcal neoformans, cryptococcal neoformans gatti, and then cryptococcal neoformans grubi was removed. So this is from pigeon droppings containing the serotypes A or D, and the infection is actually acquired through inhalation. It leads to meningitis in patients with AIDS, and it's actually a late feature when the CD4 count also drops below 100. This is one of the common causes of meningitis along with TB. So clinical features are going to be low-grade fever, nausea, vomiting, headaches. You may have fever, you may have mucorigidity, but these are often mild and sometimes lacking. You may have papilloedema in a third of the patients, neck stiffness, photophobia, which are meningeal signs in 30% of the cases. In the late manifestations, there may be confusions, altered mental state, there may be coma, they may have these extracranial manifestations. Remember that it's a multisystemic disease, so it can affect the pulmonary system, it can cause disseminated infection, even including the skin. You may have cutaneous cryptococcosis, which you see this centrally umbilicated multiple lesions on the face. They look very much like molluscum contagiosum. I will also show you a picture of this when we look at the revision live stream. Then of course, the pulmonary disease, you may have fungemia, you may have a lymphadenopathy, and of course the prostate gland may be a reservoir for smoldering infection. Then of course diagnosis is of course a lumbar puncture, so CSF analysis. You're going to see an opening pressure that is high. White blood cell count with a differential is very important. Then of course protein, glucose is normal. And then the India ink, when you stain it with the India ink, then it's positive in 60 to 80% of the cases. I will show you an image of what this looks like also on the live stream. Then of course cryptococcal antigen, CSF antigen test is positive in 95 to 99%. A cryptococcal culture is actually the gold standard. Treatment is going to be in 3 predominant phases: induction, consolidation, maintenance. Of course, I'll talk about this in so much detail in a video that's dedicated just for cryptococcal meningitis. But for now, know that it's divided into induction, consolidation, maintenance. So the induction is with amphotericin B, 0.7 to 1 milligram per kg for 2 weeks, 2 to 3 weeks. And then with fluconazole, 800 milligrams per day. Then consolidation phase is with fluconazole, 400 milligrams per day, daily. Then you stop the amphotericin B. You give this for 8 to 10 weeks or until the CSF is actually sterile. Then the maintenance is fluconazole 200 milligrams orally, lifelong. And then we discontinue the treatment or the secondary prophylaxis we may if the CD4 count is greater than 200 for at least 6 months after the patient is actually even started on treatment. Adjuvant treatment, if there is raised intracranial pressure, we generally want to do a lumbar puncture. It's both therapeutic and diagnostic in cryptococcal meningitis. There is actually no place for dexamethasone. Then we move on to progressive multifocal leukoencephalopathy. So this is actually due to reactivation by the JC virus, not Jesus Christ, but John Cunningham virus. So this is actually seen in 2 to 4 patients with AIDS. Then of course this is characterized by this progressive damage. Remember, pathy, it means there's some damage of some sort. Inflammation of the white matter, leuko means the white of the brain, encephalopathy at multiple locations, multiple. So if you look at the word itself, it's a progressive damage that is going to be as a result of inflammation of the white matter of the brain at multiple locations. That's what we call as a progressive multifocal leukoencephalopathy. So it occurs late in the course of HIV when the CD4 count is less than 100 cells. There is a subacute onset. The patient is febrile, alert, without headache. Then they may have some multifocal neurological deficits. They may have a classic triad of dementia, hemiparesis, and hemianopsia. The diagnosis: CSF is actually not so diagnostic. So the CT scan may actually show these multifocal, non-contrast enhancing hypodense lesions without any mass effect, but of course MRI is much more sensitive. So the commonly affected areas are the cortical white matter of the frontal as well as the parietal occipital lobes. Now the lesions can actually occur anywhere else in the brain as well. Serology, in 90% of the adults, they may actually be positive for this virus, but this is not useful in making a diagnosis. We may sometimes do a PCR or brain biopsy to make a diagnosis, and there is no effective treatment for this, but we initiate the patients on ART. This is supposed to increase their survival rates. Then we move on now to, so those are the opportunistic infections. CNS opportunistic infections. We now move on to CNS malignancies. So this occurs late in the course of HIV when the CD4 count is less than 100. They present with confusion, lethargy, memory loss in 57% of the cases of primary CNS lymphomas. They may present with hemiparesis, aphasia in 40%, seizures in 14%, cranial nerve palsies in 9%, headaches only in 3%, and then there is no fever unless there is a concomitant infection. Now the diagnosis, we're going going to do a CT scan or an MRI where you see these multiple lesions, they can sometimes be single lesions, they are irregular, and there's a solid enhancement, there is a subepidermal enhancement which is more specific. There's variable mass effect in these. They're usually localization, or they're localized in the periventricular area. I will show you one again on the OSCE stations when we do the revision in the live stream. Then of course the CSF, you can sometimes do EBV DNA PCR on the CSF, because remember that lymphomas are usually associated with EBV. It's 85 to 100% sensitive, 98 to 100% specific. Then of course histology shows you this diffuse infiltrating multicentric tumors of B-cell lineages with the presence of EBV genome in approximately 100% of the cases. Treatment is with cytotoxic chemotherapy, though it's not so effective. Radiotherapy can help some patients, and the response to the steroids actually varies among many patients. We should start them on treatment for HIV as well. Now, what about seizures in HIV patients? Because they are actually common. They're a frequent complication of HIV infection. So they may actually be due to one of three things. They may be due to opportunistic infections, they may be due to neoplasms, they may be due to HIV encephalitis rather. So remember that the seizure threshold is actually much lower than the normal seizure threshold in patients that have HIV infection, because of the HIV is usually associated with a lot of these electrolyte imbalances. Remember that CNS infections increase the release of ADH, which is the syndrome of inappropriate ADH secretion, which causes reabsorption of water. It causes dilution of sodium in the bloodstream. So they have what is known as a euvolemic hyponatremia. Common causes include CNS toxoplasmosis, primary CNS lymphomas, cryptococcal meningitis, and even HIV encephalopathy. Now, treatment, most of the patients who actually have 2 or more seizures that are going to be suggesting that an anticonvulsant is indicated. And in all patients with HIV infections and seizures, unless a rapidly correctable cause is found, but we want to start them actually on anti-epileptic drugs. So phenytoin remains the initial treatment of choice, 100 milligrams orally 3 times a day, but phenobarb, 100 milligrams orally every night, or valproic acid can be actually used as an alternative. Valproic acid is actually one that you can use, but this actually has to be monitored on a regular basis. Now we move on now to the respiratory manifestations, which are by far the most common manifestations in terms of opportunistic infections. So there's a wide spectrum of pulmonary manifestations. They may be due to opportunistic infections, bacterial. Of course, these do have the propensity to cause pneumonias in individuals that do not have HIV, but they're even worse off in individuals that have HIV. Streptococcal, Haemophilus influenza, gram-negative bacteria, staphylococcus, mycobacterium like Mycobacterium tuberculosis, Mycobacterium kansasi, Mycobacterium avium intracellulae. Then you may have fungi like Pneumocystis jirovecii, Cryptococcal neoformans, histoplasmosis, coccidiomycosis, aspergillosis, viruses like CMV, herpes simplex, parasites like toxoplasmosis, strongyloidiasis. Then of course opportunistic infections like pulmonary Kaposi sarcoma, which we'll talk about in detail, non-Hodgkin lymphoma. Then of course the types of opportunistic infections and malignancies actually depend on the degree of immunosuppression. So here's a table. So at any CD4 count level, you may have sinusitis, pharyngitis, acute bronchitis, bacterial pneumonias, TB, and even non-Hodgkin lymphoma. Less than 500, bacterial pneumonias and pulmonary TB become very common. Less than 200, Pneumocystis jirovecii pneumonia, Cryptococcal neoformans pneumonia, bacterial pneumonias associated with sepsis, as well as disseminated or extrapulmonary TB become common. Less than 100, pulmonary Kaposi sarcoma, bacterial pneumonias, especially gram-negative bacilli, Staphylococcus aureus, as well as toxoplasma pneumonitis become very common. Less than 50, that's why you have disseminated fungal infections. So disseminated Histoplasma capsulatum, disseminated Coccidioides immitis, cytomegalovirus pneumonitis, disseminated Mycobacterium avium complex, disseminated Mycobacterium, which is non-tuberculous, then of course the Aspergillus species type of pneumonia. So these are the different types of manifestations according to the different types of levels of the CD4 count. We'll begin with bacterial pneumonia. Remember that the most common agent is Streptococcus pneumoniae, and the causes actually vary or they worsen with the degree of immunosuppression. So you may get these features of abrupt onset of fever, You may get cough, a productive or purulent sputum, dyspnea. You may have a pleuritic chest pain. Now, the recommended investigations are a chest x-ray. Remember that in some HIV patients, those that are completely immunosuppressed or those that have a very low immunity, you may actually get a normal chest x-ray. That does not rule out them not having the disease, because for you to actually see those manifestations you like talking about on the x-ray, often you need an immune system to fight against this infection. But either way, you may see pneumonic consolidations, you may see infiltrates, you may see pleural effusions. You also want to get a blood culture, full blood count that may show leukocytosis. You may have a gram stain of the sputum microscopy culture. Treatment is with antibiotics, penicillins. Amoxicillins are now rather some bacteria resistance to it. You may also have fluoroquinolones as well as supplemental oxygen. Then when it comes to pneumocystis jirovecii, this is caused by pneumocystis jirovecii. It is actually one of the most commonest opportunistic infections in industrialized countries. It's actually due to initiation of antiretroviral therapy and the use of cotrimoxazole or prophylaxis that its incidence has actually reduced. 50% of the patients actually experience at least one bout of PCP during their lifetime. It was previously referred to as pneumocystis carinii, but pneumocystis carinii is actually affecting rats, so we renamed it to pneumocystis jirovecii. It's transmitted from human to human as well as from the environmental reservoirs to humans. So it's going to be presenting to you with this indolent course characterized by weeks of vague symptoms and presentation, or even they may have a median duration of symptoms of about 28 days. So they have dyspnea. They may have a fever, which are the cardinal symptoms. They may have cough with scanty sputum. Most of the times they don't really produce sputum. So the physical examination reveals the findings may actually be minimal. Usually you get findings of pneumonia, which, or you may, unusual findings, or you may not find the findings of pneumonia per se. So you get respiratory distress, cyanosis. These people tend to desaturate very quickly. There's little abnormality on the chest x-ray. You may hear some rhonchi or wheezing, especially in the patients with some other underlying pulmonary disease. There may also be some findings of consolidation, which are usually absent. And then pneumocystis jirovecii actually appears to be capable of hematogenically spreading with seeding to various organs and various systems when you have the primary infection in the ear. It actually can cause a primary infection in the ear. So what's the diagnostic workup? A chest x-ray, which may be normal, like I said, or it may show you this diffuse bilateral alveolar or interstitial infiltrate. So you may see this angel wing pattern. Then of course, lactate dehydrogenase is often elevated. It's very and it has a very high negative predictive value. So if the LDH level is low in a patient with a diagnosis of PCP, then it's unlikely. Then the definitive diagnosis is to demonstrate the trophozoites or the cysts from the organism in the samples that you obtain from the induced sputum, in which yields about 60%, or a bronchoalveolar lavage in about 95%. The stains that we use are Wright stain or Gimza. You can also use methamine silver. Of course, you may also perform direct immunofluorescence or PCR. Other tests include a gallium 69 scan, and then you may also even have things like pulmonary function tests as well as arterial blood gases. What's the treatment? Gold standard is of course your cotrimoxazole, IV or orally. So your dose is 15 milligrams per kg per day of trimethoprim in 3 to 4 divided doses. That's about 3 to 4 tablets of 480 milligrams 4 times a day. So the duration is 21 days, so 3 weeks. Side effects include a rash, fever, or leukopenia. Response to treatment may actually not occur until the end of the first week, and the patients may actually get worse when you start them on treatment on the very first few days, because there's an inflammatory response that's going to result from the death of the large number of organisms in the lungs, kind of similar to what we see in syphilis with the Jarisch-Hexheimer reaction. Then of course, alternatives include clindamycin 600 milligrams, IV 8 hourly, or 300 to 400 orally 6 hourly, plus pyrimethamine 15 to 30 milligrams a day. Then of course, this is for 21 days. Then pentamidine 4 milligrams per kg per day IV for 21 days, or atfuaquan 750 milligrams orally twice a day with a meal for 21 days. Adjuvant treatment, of course, give them supplemental oxygen. Steroids actually reduce the need for mechanical ventilation, and they reduce the mortality in 50% of the cases. So you should start them within 72 hours of presentation. Indications of you giving steroids include moderate to severe respiratory distress or cyanosis, an oxygen partial pressure less than 70. Prednisolone can be given, your 40 milligrams tablets, twice a day for 5 days. Then 40 milligrams orally daily for 5 days, then 20 milligrams orally daily for 11 days. Remember, steroids are usually tapered off. Then, of course, prophylaxis, primary prophylaxis. It's recommended for HIV infected patients with evidence of significant immunodeficiency. So here the threshold is now at 350 cells per microliter. Then, of course, HIV-associated thrush, unexplained fever. Secondary prophylaxis is for those patients that have had a previous episode of PCP. So the regimens use your trimethoprim sulfamethoxazole 2 tablets a day. That's the single strength, or these 2 tablets a day 3 times a week. Then, of course, alternatives are Dapsone 100 milligrams orally daily, Dapsone 50 milligrams orally plus pyrimethamine 50 milligrams orally plus folinic acid 25 milligrams orally. Then, of course, aerosolized pentamidine 300 milligrams monthly via nebulizer. Then Advacon 1500 milligrams daily can also be given. So prevention of PCV may be actually beneficial in reducing the risk of other HIV associated infections such as CNS toxoplasmosis and bacterial infections. As we have already seen, these regimens are very similar to what we talked about earlier on. Then we move on to TB. This is actually the leading opportunistic infection in developing countries. So HIV is actually the most potent known factor to increase the risk of progression of in the different forms of Mycobacterium tuberculosis infection to actually active disease. So clinical presentation also depends on the immunosuppression. So generally, in the early stage of the infection, those that have a CD4 greater than 200, the clinical presentation is similar to those that do not have HIV. So they have this productive cough, pulmonary manifestations are going to predominate. Those that have HIV in the late stages, when the CD4 count is less than 200, they have an atypical presentation. So they may present to you with extrapulmonary TB, which is very common. The TB tends to be disseminated, so it can involve different organs like TB meningitis, TB of the pleura, TB pericarditis, TB adenitis. Then, of course, when you do a diagnosis via your sputum, then it's often positive, and then the purifying protein derivative test, or the PPD, the tuberculin skin test, is often reactive in more than 10% of individuals in the early stage, and then in the late stage it's often negative. Both tests are often negative, and there's actually no reaction that you may actually get. Then on the chest x-ray, someone who's greater than 200 cells, so you have typical chest x-ray findings of TB, upper lobe and even bilateral infiltrates, cavitations, pulmonary fibrosis. Those that are less than 200, you get atypical findings. So the chest x-ray may show these interstitial infiltrates, especially in the lower zones. There are no features of cavitations, no features of fibrosis, and negative chest x-ray can actually be seen with those that have sputum AFP positive in about 12% of the cases. Now, what are some of the drugs that we actually give in TB? I also do a separate lecture just on TB. So we give rifampicin, isoniazid, ethambutol, and pyrazinamide. Just remember RIPE. So remember that rifampicin is bactericidal within 1 hour, high potency, most effective sterilizing drug. So here it targets all populations, including the dormant bacilli, and the site of action is intracellular and extracellular. Isoniazid is bactericidal after 24 hours. It has a high potency, kills more than 90% of the bacilli in the first few days of treatment. The target bacilli are those that are rapid and intermediately growing. It also works with intracellular and extracellular mechanisms. These two are the backbone of the TB regimen, because we're going to be continuing with this drug throughout the entire regimen. Then, of course, ethambutol is bacteriostatic. It has a low potency, and it minimizes the emergence of drug resistance. It works on all bacterial populations, intracellular and extracellular sites of action. Pyrazinamide is actually bactericidal with a low potency, and it achieves its sterilizing effects usually within 2 to 3 months. So it works on the slow growing bacilli and has intracellular bacilli. It works on the intracellular bacilli in the macrophages. Then how do we manage TB? So our standard treatment is actually using the 4 FDCs, the full fixed dose combination regimen. and the 2 fixed dose combination regimen of rifampicin and isoniazid. The 4 fixed dose regimen uses rifampicin, isoniazid, pyrazinamide, and ethambutol. Then, of course, for a period of 6 to 12 months, depending on the severity and the anatomical location of the disease. So we divide the TB treatment into 2 phases, the intensive phase and the continuation phase. So the intensive phase is actually made to rapidly kill any actively growing or semi-dormant bacilli. It achieves a short duration of infectiousness. So we want to shorten the duration of infectiousness of this patient. So usually it's 2 months. In whether it's new cases or retreatment cases, it's always fixed. It's usually 2 months. Then the continuation phase here eliminates the bacilli that are still multiplying, and it reduces the risk of failure as well as relapse. And this duration is at least 4 months in some cases. In some cases, when you're treating for 1 year, we actually go for 10 months. For example, in patients with TB meningitis, TB osteoarthritis, or TB affecting the bones and the joints, as well as spinal TB. Those are complicated forms. So it is recommended to actually extend to 12 months in certain types of TB, like TB meningitis, because of the risk of disability and mortality. Osteoarticular TB and spinal TB because of difficulties of assessing response to treatment. Then, of course, the management, like I said, for all forms of TB, intensive phase 2, that's the non-severe, all forms. 2 months, intensive phase of rifampicin, isoniazid, pyrazinamide, and ethambutol. Then continuation phase of 4 months of the 2 drugs, rifampicin and isoniazid. Then TB meningitis, osteoarticular TB, as well as spinal TB. These are severe forms. 2 months intensive phase of rifampicin, isoniazid, pyrazinamide, and ethambutol. Then 10 months of rifampicin and isoniazid. So here is the dosing of the patient according to the different weight classes. Those that are between 25 to 37 kg, 38 to 54, 55 to 70, and those that are above 71. Now, what are the indications of using steroids in TB management? So we use steroids in TB meningitis, we use steroids in constrictive pericarditis with suspected constrictive physiology. We use it in TB IRIS, we use it in massive pleural effusions, we use it in massive lymphadenopathy with pressure effects, we use it with severe hypersensitivity reactions to anti-TB drugs. Then other indications include hypoadrenalism, renal tract TB to prevent any ureteric scarring, and then of course TB laryngitis when there is life-threatening airway obstruction. We can actually use steroids in this case. So here's the dosing of the different types of steroids that we use in TB meningitis, TB pericarditis, as well as TB affecting with the pleural effusion, as well as a TB iris. So here are the dosing and how it's given. Just take your time to pause this right here, get a screenshot of it. It's actually self-explanatory. Now with this here, it's pretty much the different populations and different scenarios. A pregnant woman on ART and develops TB, so on and so forth. This is also self-explanatory and what you're supposed to do, recommended according to the guidelines. So you can also pause the video here, get a screenshot of this. I'll leave it on your screen right here. Get a screenshot of it, then actually read through. It's actually very self-explanatory. Then we move on now to the GIT. So you may have diarrheas in HIV patients. So this is a common condition in over 50% of HIV infected patients. It may be acute or chronic. There is this watery, mucoid, or bloody type of diarrhea. It may or may not be associated with a fever. The spectrum of the condition actually varies with the degree of immunodeficiency. So pathogens could be bacterial, viral, protozoa, fungal, spirochetal, mycobacterial, metazoa, or even other malignancies that may cause diarrhea in HIV patients. Mechanisms are varied as well. It could be due to adhesion of the microorganism to the surface. It could be due to an enterotoxin that is being produced, or enteroinvasion by the certain pathogen, or even atrophy of the mucosa, because we tend to see this in HIV patients. Now with the chronic diarrheas, this is a diarrhea that's lasting more than 2 weeks with a single watery bowel motion or 3 or more loose stools per day. So the frequency of diarrhea actually increases as the CD4 count falls, and with retroviral therapy, the incidence of chronic diarrhea actually decreases. Now, protozoa causing chronic diarrhea that I want you to remember: Cryptosporidium parvum, Isospora belli, and Microsporidium. Then, of course, you may have HIV enteropathy or AIDS enteropathy, which is just this chronic diarrheal syndrome. There's no etiological agent other than HIV that has been identified. So it's a chronic diarrhea of an unknown cause. So in the early stages, it's intermittent, self-limiting. However, in the advanced stages, it may have this persistent, life-threatening diarrhea. You get this copious amounts of stool several times a day, and it may be associated with abdominal cramps, nausea, and vomiting. There may be some significant weight loss. There may be some wasting that may occur due to the associated malabsorption, as well as fluid and electrolyte depletion. Diagnosis is by stool microscopy culture sensitivity. Special stains like the modified acid-fast bacilli stain or the modified ZN stain can be used, as well as an intestinal biopsy. Generally, the treatment is to rehydrate the patient, maybe orally or parenterally, to replace them with electrolytes. Then, of course, symptomatic treatment with antidiarrheal agents only if the diarrhea is life-threatening. So we can use loperamide 2 to 4 milligrams 4 times a day. We can use Lomotil 5 milligrams QID, and the other codeine tablets and all those things which you can't really get over the counter unless if you have a prescription. So specific treatments: Cryptosporidium is treated with nitazoxamide 0.5 to 1 gram twice a day, or paromomycin 1 gram twice a day, plus azithromycin 600 milligrams 4 times a day. Then Isospora is treated with cotrimoxazole 2 tablets 4 times a day for 10 days, then twice a day for 3 weeks, or pyrimethamine 75 milligrams plus folinic acid. Then chronic suppression or secondary prophylaxis is with the cotrimoxazole 2 tablets a day, or pyrimethamine 25 milligrams plus folinic acid 5 milligrams 4 times a day. Then we also have strongyloidiasis, which is caused by Strongyloids tecoralis. It is acquired through skin penetration of its larvae, and an autoinfection can actually occur. So its life cycle actually there is the strongyloid actually passes through the lungs and then it settles in the GIT. So primarily in the small intestine as a free living or sometimes a parasitic parasite. So usually a mild disease in immunocompetent patients, but in immunocompromised it may have disseminated disease. So in the immunocompetent they may be asymptomatic, or they may have mild symptoms with occasional severe pruritus. This is severe itching. They may have this mild diarrhea and epigastric pain. In those that are immunocompromised, they have large amounts of filariform larvae that are released, and these may actually invade into the GIT, causing enteritis with a severe type of diarrhea and malabsorption. They may manifest with what is known as low flush syndrome in the lungs, where they manifest as cough, shortness of breath. You may have CNS, peritoneal, and even liver invasion. You may have severe systemic symptoms that are common in disseminated infections, and usually it's complicated by gram-negative sepsis. Now the treatment is ivermectin 200 milligrams for 1 or 2 days, thiabendazole, which is 75 milligrams twice a day for 3 days, albendazole 400 milligrams daily for 5 days. Now, Kaposi sarcoma will also take some time here. So remember, this is a tumor of the vascular and lymphatic endothelium. It's going to be presenting to you as purplish nodules, plaques on the skin and mucosa. It was first described by Moritz Kaposi in 1872. I hope I haven't butchered the pronunciation of his name. Then, of course, the immunosuppression increases the risk of Kaposi sarcoma 400 to 500 times higher than the general population. Remember that this is going to be associated with human herpes virus 8, HHV8, and is actually found in all the types of KS. And of course, it has a worldwide distribution, but it largely occurs south of the Sahara, and the prevalence of AIDS-related KS has decreased because of the initiation of treatment of HIV. KS is also often associated with other forms of immunosuppression as outside HIV, and of course, it may be as a result of iatrogenic suppression, for example, someone taking oral prednisolone or chronic immunosuppressive therapies after an organ transplant. It affects more men than women with a ratio of 2 to 1 and is actually the most common cutaneous manifestation of HIV. Now, the condition carries a variable clinical course ranging from minimal cutaneous disease to extensive organ involvement. There may be some various visceral organs that are affected. I will show you the clinical features very shortly. And it has several subtypes according to the presentation, epidemiology, as well as prognosis. Now, remember that the Kaposi sarcoma is formed by abnormal proliferation of vascular endothelial cells, and it's going to be in response to HHV8, human herpes virus 8. Now, remember that this can be transmitted through saliva, organ transplantation, blood transfusion, and even to some extent sexually. Now, the titers are 2 to 3 times higher in saliva than in semen, anorectal, and even prostate samples. And it's not really known how HSV actually causes the cancer, but what we actually know is that it encodes for products that lead to growth dysregulation and evasion of the immune surveillance. So a virally encoded G protein actually induces vascular endothelial derived growth factor, which actually stimulates endothelial growth. Then, of course, the cytokines that are going to be produced by these inflammatory cells recruit to the site of the lytic infection and also create a local proliferative environment. And then other proteins can actually disrupt the normal cellular proliferation and also prevent apoptosis by inhibiting your P53 gene. Then, of course, the HIV virus touch protein actually potentiates the environment and makes it conducive for Kaposi sarcoma growth. Now, what are the clinical features? It can affect almost any organ in the system. Generally, they get these cutaneous lesions that can occur at any locations. We usually see the first lesions in the palate. So just look in the mouth, look in the palate. You see these purple-like lesions. So it may be concentrated to the lower extremities. It may be concentrated to the head and the neck region. Characteristically, you're going to be seeing this brown, pink, red, violaceous macules, patches, papules, plaques, or nodules. If you have no idea what these are, just head over to the dermatology playlist, and actually I explained all these skin lesions and I explained all the skin terms in the primary skin lesions and secondary skin lesions very well. Then all the lesions are nearly palpable and non-pruritic. They're not so itchy. The lesions may actually vary in size from several millimeters to several centimeters. The lesions may be brown, pink, red, violaceous, and they may be difficult to actually distinguish in a dark-skinned individual. The lesions are often discrete or confluent and typically appear in a linear, symmetrical, or they follow the lines of Langer on your skin. Then, of course, there may be mucous membrane involvement in the palate, the gingiva, and even the conjunctiva. I'll show you pictures very shortly. Then, of course, the lesion may vary depending on the clinical variant. Generally, you have mucous membrane, cutaneous, visceral involvement, which is common. That's the lymph nodes, the GIT, and the lungs. You may have 4 types of Kaposi sarcoma: your classic or sporadic, African cutaneous or endemic, AIDS-associated or epidemic, immunosuppressant therapy, which is known as the iatrogenic related. So here's what the lesions look like on a foot as well as in the mouth. I will show you other images on the OSCE stations in the live stream on Sunday. So let's talk about the different subtypes. You have the classical Kaposi sarcoma, which is usually an indolent disease, very common in the middle-aged women of Southern as well as Eastern Europe origin. It's not associated with HIV. So here you have these early lesions, which are most common on the toes or the soles. They are reddish, they are violaceous, they are sometimes bluish-black macules, patches that spread and coalesce to form nodules and plaques. You may have some browny edema that may be present, and the macules or nodules usually appear much later on the arms and the hands, and rarely do they extend to the face, ears, trunk, genitalia, or oral mucosa. The classic Kaposi sarcoma has a slow progression. Then, of course, African cutaneous or the endemic is, of course, associated with HIV. It's endemic in the tropical Africa. It's seen most commonly in men between the ages of 20 to 50. Then it's locally aggressive, but systemically it actually is a benign course. Then, of course, it's characterized by nodular or infiltrating vascular masses on the extremities. So a particular severe form can actually affect the lymph nodes, and it can affect the viscera, and it actually happens in prepubertal children where you get just this unilateral swelling of the leg. It's known as the African lymphadenopathic Kaposi sarcoma. This one actually carries 100% mortality. I will show you a picture of this in the live stream as well. Then an aggressive disease of young patients, mainly children under the age of 10, the lymph node involvement with or without the skin lesion, and there's an aggressive course. Often the patients die within 2 years of onset. Then you may have an AIDS-associated Kaposi sarcoma, obviously associated with AIDS. It carries a very aggressive course. It's the most common presentation of Kaposi sarcoma. So here you get the cutaneous lesions that begin as one or several red to purple macules that progress to papules, nodules, and flakes. Then, of course, there is a predilection to the hands, the neck, the trunk, and the mucous membranes. You may sometimes get a fulminant progressive course with nodular as well as systemic involvement that is expected, and it's actually usually seen in stage 4 disease, HIV stage 4. You may also get an immunosuppression associated Kaposi sarcoma, which is associated with immunosuppressive therapy. The clinical features are very similar to classical type. However, the site of presentation is actually much more variable here. And removal of the immunosuppression actually causes the regression of the Kaposi sarcoma. Now, these are the organs that are infected. Classical KS affects the GIT most frequently. So you may have intestinal blockage, you may have bleeding. It affects the lungs, the heart, the liver, the conjunctiva, the adrenals, the abdominal lymph nodes, and even the bones. The cutaneous type usually is following a massive leg edema and sometimes some bone involvement. The African lymphadenopathic type, we already talked about this. You may have eye involvement and is associated with swelling of the lacrimal, parotid, and the submandibular glands, but usually this is reported among the Bantu children who develop massive lymph node involvement preceding the appearance of the skin lesions, and the children then develop the lesions on the eyelids and the conjunctiva. Then with AIDS-associated Kaposi sarcoma, it affects the lungs in 37% of the cases. More commonly, it affects the gastrointestinal tract and the lymph node, both in 50% of the time. The diagnosis is, of course, the skin and oral lesion biopsy. Examine them first clinically, then biopsy them to make a diagnosis. The lung and GIT lesions must also be examined by endoscopy with a biopsy as well. Then, of course, resolution of the skin lesions when you start them on treatment is actually a presumptive diagnosis that they had KS. And then, of course, we can test for HHV8, but of course, this is more research oriented. Differential diagnoses include bacillary angiomatosis, pyogenic granuloma, leukemia cutis, cellulitis, severe stasis dermatitis, as well as small vessel vasculitis. When you do your workup, you want to do a full blood count, your liver enzymes, urea, electrolytes, creatinine, RPR for syphilis. Get a skin biopsy, you'll see these three things. You see this prominent slit-like spindle cells. You see this prominent slit-like, prominent spindle-shaped cells, prominent slit-like vascular spaces, as well as extravasated red blood cells. Do not forget these three things. You're also going to be doing your immunohistochemistry and HIV test, HHV8 PCR, a chest X-ray or CT scan or endoscopy. Treatment is, of course, with topical retinoid. Some 35 to 50% of the patients respond. Surgical excision, local radiation, cryotherapy, 85% of them actually respond. Laser therapy and antiretroviral therapy for those that have epidemic KS. Chemotherapy is going to be with liposomal doxorubicin, liposomal daunorubicin. And then at UTH, our first line at CDH, we use vincristine, bleomycin, and doxorubicin. The second line is paclitaxel. And of course, the course. Classical KS is usually progressive. Rare lymph node or visceral involvement. Death usually occurs from unrelated causes. With the African cutaneous type, it's aggressive with early lymph node involvement. Death is within 1 to 2 years. With the AIDS related, although it's widespread, most patients actually die of intercurrent infections. And the immunosuppression type is actually, if you remove the immunosuppression, they may actually have the KS resolving without even therapy. Now, coming to lymphomas, remember that these occur with increased frequency in immunodeficiency states. So as the AIDS actually progresses, the risk of lymphoma also increases. So the incidence of lymphoma has not shown a drastic decrease even after we have instituted effective treatment of HIV. It's actually a late manifestation which occurs when the CD4 count falls below 200 cells. So the main categories that are seen with HIV are the grade 3 or grade 4 immunoblastic lymphomas in 60% of the time, Burkitt's lymphoma, which is associated with EBV in 20% of the time, and primary CNS lymphomas. So the treatment is, of course, in patients with a high CD4 count, we give them intensive chemotherapy, low-dose chemotherapy in patients that have a low CD4 count, and then there may also be some palliative measures to decrease the size of the lesion and associated edema, so things like radiotherapy as well as glucocorticoids. Then coming to the last thing, which is cervical cancer, there is actually a 5-fold increased risk of developing cervical cancer in women with AIDS. I think I talked about this when I talked about cervical cancer. If you haven't watched the video on cervical cancer, head over to the Obs and Gyne playlist. It's going to be associated with human papilloma virus infection, the high risk types. Then of course the invasive carcinoma of the cervix is actually an AIDS-defining illness. So an abnormal pap smear is actually seen in 60% of patients that are HIV infected in women. Then anorectal CA may also be seen in homosexual men, just also to keep that in the back of your mind. Coming back to our warm-up question, a 27-year-old HIV man comes for a revisit after a screening urinalysis reveals strikingly elevated protein levels. The patient is currently reluctant to start antiretroviral therapy, though he is taking prophylactic antibiotics. He has a distant history of injection drug use. On examination, the patient has a mild ankle edema and is slightly cachectic, but otherwise appears well. A new urinalysis reveals 3+ proteinuria without any hematuria or red cell casts. A serum albumin is 2.3 grams, which disease process is most likely to explain the patient's proteinuria? A. Minimal change disease. B. Focal segmental glomerulosclerosis. C. Membranoproliferative glomerulonephritis. D. Membranous nephropathy. E. IgA nephropathy. Remember that HIV and even intravenous drug use are often associated with focal segmental glomerulosclerosis. That indeed marks the end of HIV week. I really hope you enjoyed the ride and you enjoyed learning about HIV, and if you watch through all these videos, you have a very good perspective of how we treat HIV, what HIV is, and I hope when they release the newer guidelines, you'll just be able to update the information that you already have. If you did, consider subscribing, consider hitting the bell notification icon to be receiving notifications of such videos every time I post. Drop a like, drop a comment. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.